करोजिव का एक्सपीरियंस है मेरा, तो वो तो सारा उधर पीजीआई का ही है ना।
हाँ
अब
हाँ
यहाँ
हेलो
पे
हेलो
जिस कंट्री में मैं बैठा हूँ वहाँ करोजिव होता ही नहीं
हेलो
हाँ,
है।
बिल्कुल सर।
या
जी विकास सर।
या प्लीज।
जी सर, हमने स्टार्ट कर दिया है, हम स्टार्ट कर सकते हैं।
Right. Okay. So Dr. Dash is going to start the proceedings. Dr. Dash has not logged in.
मैं पेलू नहीं था, तो प्रेजेंटेशन ओपन नहीं था पेन।
Yeah. Anyway, so yeah. Hi. Sir. Good evening, sir. Dr. Kapoor, sir.
Yeah, I am at the railway station, but it is 7.
Yeah. I got your message.
Good
You are
evening, sir.
traveling.
Please start. Please start.
Good evening,
Yeah.
sir.
Fine.
Good evening, sir. Good evening.
Good evening. Good evening.
Okay, so good evening, everybody. So this is we are starting the masterclass on corrosive injury of the esophagus. So today the main contention for discussion is management of acute corrosive injury, and tomorrow it will be more focused on the chronic corrosive stricture of the esophagus, its evaluation and management. And I will call upon the first speaker, Dr. Harindra Sandhu. He will be speaking on this thing, evaluation of a patient of acute corrosive injury. Over to you, Dr. Harindra, please.
Okay, sir.
So before Harindra starts, I would like to say a few words about him. I'm sorry, friends, I'm at a railway station, so there is a lot of background noise. But Harindra is a young faculty colleague who's working in the Himalayan Institute in Dehradun. He's been contacting me, calling me, emailing me, WhatsApping me for discussing several issues, which I very much like and I very much enjoy. In fact, I would request all young surgical colleagues that whenever you have any problem, you need any help, any advice, any guidance, please feel free to contact me like Harindra has been doing. I really enjoy it. And Harindra volunteered. He was the first person to volunteer from the JSP group to present in this master class. So I'm very happy that he is presenting. Over to you, Harindra.
Thank you, sir. Thank you, sir. Thank you, sir.
Myself off.
Thank you very much, sir.
Yeah.
Thank you,
Sir.
Yeah.
Sir, are the screens?
Yeah, please start, Dr. Harindra.
Sir, sir, screen is.
Yeah, your screen is visible. You can proceed.
Okay, sir. मेरे सर इसमें मेरे को सर ये आ नहीं रही है सर इसमें स्क्रीन।
सर मैं कर देती हूँ स्टार्ट, आप मुझे नेक्स्ट बताते जाना।
श्योर
आप स्टॉप कर दीजिए सर।
ठीक है, मैं कर रहा हूँ इसको। So, sir, it is my great opportunity for me for I have been given the topic of corrosive esophageal injury and just the clinical evaluation of the corrosive esophageal injury. So I will be discussing on introduction, pathophysiology, and the clinical manifestations of the corrosive esophageal injury. So the introduction, so etiologies of accidental ingestions occur in pediatric patients, occur in adults and adolescents. So India is unlabeled and easily available toilet cleaners like Harpic 10% hydrochloric acid. Western countries, most commonly the strong alkali, sodium or potassium hydroxide, contained in drain cleaners, other household cleaning by products or disk batteries. So what are the common caustic substances and their uses? Classic alkalis are the ammonium hydroxide, sodium hypochlorite. Classic acids like acetic acid, hydrochloric acid, oxalic acid, phosphoric acid, sulfuric acid. And miscellaneous like cationic detergents, hydrofluoric acid, hydrogen peroxide, and phenol. I would like to emphasize on the pathophysiology of alkali-induced injury. So the alkali causes the liqueficative necrosis and thrombosis, which result in the gelatinous substance formation and which results in the further penetration and transmural damage. So it extends rapidly within seconds through the mucosa and wall of the esophagus until the tissue fluids buffer the alkali, and it can complicate by the periesophageal injury. Stomach is more limited injury, partial because it is by the partial neutralization of alkali by the gastric acid. So now the pathophysiology of acid-induced injury, acid causes the coagulation necrosis, which results in a Ishar or coagulum formation, which limits the transmural spread, and it results in reducing the incidence of full thickness injury. It is the less viscous and tends to pass quickly into the stomach, and it causes less esophageal damage as acids causes less esophageal damage. Acid solutions can cause pain on contact with oropharynx, and amount of acid ingested tends to be limited. Upper airway injuries are more common with the ingestion of acid, and acid results in reflux pyelospasm, which causes the increase in the gastric contact time, which results in the preferentially antral involvement in the stomach. So the natural history of corrosive injury in within 24 hours, there was a destruction of the epithelium and liquefaction of the submucosal layer, acute inflammatory, cellular and bacterial penetration. Within day to 5 days, it necrosis sets in the superficial layers, whereas in days 6 to 7, there is a demarcation between the necrotic and non-necrotic tissue, and ulcerative granulation tissues develop 6 to 7 days. And 8 to 10 days, there's a reparative process, collagen laid down, and there is a structure formation from 13 to 28 days. So this is the histologic phases of caustic injury to the esophagus, there are 3 phases: acute necrotic phase, which is within 3 days; ulcerative granular phase, which results from 3 days to 3 weeks; and cicatrization and stricturing from 3 weeks to 3 months. Which histopathologic findings in acute necrotic is the liquefaction necrosis of the superficial layers of the esophagus, acute inflammation, thrombosis of the vasculature, bacterial and hemorrhagic infiltration of the underlying tissues. In the ulcerative causes sloughing of the superficial necrotic tissues, ulceration occurs in development of fresh granulation tissue, development of new blood vessels, infiltration of fibroblast, and early collagenous product producing connective tissues. And cicatrization stricture causes ongoing formation of collagenous connective tissue, submucous muscularis replaced with dense fibrosis, and decreased inflammatory response, and reproliferation with the squamous cells. What are the determinants of severity of the corrosive injury? The corrosive, it depends upon the corrosive property. What is the pH of the ingested substance taken? How much the amount has been taken? What is the duration of the contact with the mucosa? The upper air injuries are more common with the ingestion of acids, perhaps related to their bad taste, which tends to stimulate. What are the symptoms? Symptoms and signs may not correlate with the severity and extent of tissue injury. Pain and inability to clear pharyngeal secretions will result in persistent drooling, the oropharyngeal injury, host pneumonia, which causes retrosternal. So, what are the vital signs? Examination of the oral membranes. Patients in respiratory will result in laryngoscopy to evaluate the need for intubation and the absence of. The fever, tachycardia, shock, presence of more severe extensive injury, and subcutaneous emphysema, esophageal perforation. 20 to 25% of patients can be normal physical examination. So they develop. So this is an important scores. There are the clinical scores which needs to evaluate in a patient of gastric caustic corrosive injury. The drool score, which can be remembered by the component of the canonic: drooling, reluctance, oropharynx, others, and leukocytosis. Drooling of saliva, there is a score for given from 0 to 2. If there is a drooling of saliva for greater than 12 hours, then it is a score of 0. And if a reluctance to eat or dysphagia or food intolerance, then for more than 24 hours, then the score of 0 and oropharyngeal burns. If there are severe lesions or high blood salt count greater than 20,000, so it is the score ranges from 0 to 10. And if the score is less than equal to 4, then there are more chances of esophageal stricture formation. So this is a score to prognosticate the corrosive injury. So what are the lab investigations which needs to be done for the patient? The predictors of transmural necrosis and poor outcomes, there are leukocytosis, there is a high leukocyte count, high serum C-reactive protein, severe acidosis, low pH, and high blood lactate concentration. There can be renal failure, deranged LFTs, and thrombocytopenia. So what can be the findings on the chest X-ray? There can be mediastinal air, pleural effusions, pneumoperitoneum, and aspiration pneumonitis. And contrast esophagram can assess for the esophageal perforation. And use of barium is felt to decrease pneumonitis in the setting of aspiration, but irritate the peritoneal pleural cavity if a perforation is present. And the other is CECT.
Yeah. Thank you, Dr. Harinder. So I think
Thank you.
once we have all the presentations, we can have discussion in the last.
Sure, sir.
So
Sure, sir. Sure.
yeah.
Thank you, sir.
So yeah, going from here, so we move on to the next speaker, Dr. Anupam. He is a consultant faculty in Department of Medical Gastroenterology, PGI Chandigarh, and he has been a good colleague of mine, and we have worked together quite a bit. So he will be speaking on endoscopic and radiological evaluation of a patient with the corrosive stricture, because this is a very important component and this determines the further outcome. So over to you, Dr. Anupam.
Hello. Thank you, sir, for the kind introduction and allowing me to speak on this topic, that is investigations in acute caustic injury. So are my slides visible, sir? Anyone?
Yeah, yes, your slides are visible. You can
Okay, thank
go.
you, sir. So what I will be discussing in the topic is actually related to the investigation which should be done in the acute caustic injury. So I have nothing to disclose for this topic. And over the next few minutes, what I will be discussing is about the lab investigations which should be done, the upper GI endoscopy, and then we will be moving to the CT scan and which investigation we should choose among the upper GI and CT scan. So let's discuss two case scenarios where a 23-year male with accidental ingestion of a toilet cleaner, that is the HCl, presented with recurrent vomiting and epigastric pain. And on examination, he had tachycardia, tachypnea, and systemic examination also revealed tenderness in the epigastric region. While the second patient is a 35-year female with a suicidal ingestion of tile cleaner, and it was only in small amount, but patient was asymptomatic, vitals were stable, and systemic examination was normal for this patient. So the question that comes to our mind that the first patient is symptomatic with systemic findings, second is asymptomatic and no systemic findings. So who actually needs evaluation and what are the reliability of these clinical findings with which the patient present? So obviously, clinically, patient should be assessed, and there are several clinical scores which have been among the studies which has been performed in various from various centers, but none have stood the time. And actually, that is the reason that several authors have used or described several different scores to predict the severity, but none is foolproof. And that is why most of the authors as well as the reviewers suggest that the assessment should be whole, and that should include the clinical, the laboratory, as well as the imaging parameter. So what are the initial investigation which should be done for all the patient? And the first CBC should be done because the presence of neutrophilia with more than 75% of neutrophils are suggestive of severe injury in few studies, then a baseline renal function test, liver function test should be done in all the patients. Chest X-ray and EXR should be done to rule out any kind of pulmonary pathology or the presence of air under the diaphragm. And ABG, if possible, should be done in all the patients whenever available, because the presence of acidosis with a bicarbonate of less than 22 is found to predict the in-hospital outcome in all these patients. So these are the basic investigation which we should do in all the patients. But apart from these investigations, there are two investigations which should be done to look at the severity and extent, and that is the upper GI endoscopy and the CT chest and abdomen. The question is which investigation we should choose. So let's discuss about these investigations regarding the upper GI. The first question that comes in our mind, why we should do the endoscopy. So obviously the clinical evaluation and scores, whichever we are having, are not sensitive or specific enough to rule out or rule in all the important injury. And again, using endoscopy, you can assess the extent as well as the severity of injury with great specificity. And obviously, the use of endoscopy by assessing the severity of injury, you can predict the outcome, the in-hospital outcome, as well as the long-term outcome in the form of stricture formation, as well as the low-grade injury. By identifying on endoscopy, you can decide whether the patient should be admitted or patient can be early discharged. And that's why it helps in management decision. So the next question is, when the endoscopy should be performed. So this slide, which was also shown by the previous speaker, I have shown that if we move from acute inflammation, which was the initial event which occurs in the caustic ingestion, and later on moves to necrosis, granulation, and then reparative process starts. So from day 2 onwards till day 14, this is the phase when the esophageal wall is the thinnest and the weakest. So most of the papers as well as the reviewers suggest that the endoscopy should not be done in this phase. And in fact, the initial 24 to 48 hours has been considered the most safest duration where the endoscopy should be performed. But what should be known, or what we should know, that this natural history was way back given in 1955, and that too on the animal model. And subsequent studies, so this study was done when the time was only of rigid scope, but now we are having flexible scope. So obviously it is safe to do. Even if a patient is presenting late, we can do. But for all practical purposes, endoscopy should be done as early as possible, and preferably in the initial 24 to 48 hours. So whenever we are doing the endoscopy for assessment, the assessment is by using a traditional classification, that is Zerger classification. It's a 6-grade system. And what it says that it broadly divides the grading into the 3 parts. The grade 0 or 1 is normal. The grade 2 is presence of ulcer, while grade 3 is presence of necrosis. And further, these has been divided into different parts. So these are the various pictures. In grade 1, the esophagus is absolutely normal. In the grade 1 grading, Zerger grade 1 injury, there is only a small amount of hyperemia or mucosal edema. That is the only finding. In grade 2A, you can have the whitish membrane, or there could be superficial ulcerations. Grade 2, when the whole of the circumference of esophagus is involved by the ulceration, that is what we call grade 2. And over and above that ulceration, if the patient is having these small black spots which are suggestive of necrosis, it is categorized as grade 3A. And then grade 3B is extensive necrosis of the whole of the circumference. That is how we classify grade 3. So an important aspect of this classification is also we can subclassify these gradings into 2 parts, into low risk injuries and high risk injuries. So low risk injuries is whenever a patient is having Zerger grade 2A and below, and high grade whenever a patient is having 2B and above. So why it is important? Because study have shown that if a patient is having low grade injury, the complications rate are nil. Patient can be started on early feeding, and early discharge can be done once the patient is able to swallow. And similarly, if a patient is having high risk, these patients are subsequently likely to have high complications during the subsequent period, and these patients should not be discharged, should be admitted, and should be observed. nutrition supplementary should be given, and these may require prolonged hospitalization. So coming to what are the indications? So for all practical purposes, you should do endoscopy in all patients of caustic injury or corrosive injury who are coming to us and are in hemodynamically stable condition. However, what is important to know that when you should not do or attempt to do an endoscopy, if a patient is hemodynamically unstable, there are any evidences, sign or symptoms of mediastinitis or peritonitis, if there is extensive necrosis which is seen on endoscopy, you should not go beyond that area. So if you are able to see till G junction where there is extensive necrosis, you should avoid doing the full endoscopy. Whenever there is non-availability of experienced endoscopy should not be done. And if there is respiratory distress or stridor, again, the endoscopy should not be done. However, there are various limitations of the endoscopy. One, it is an invasive. Obviously, because of the invasive nature, it carries the risk of perforation. Sometimes, because there are inter-individual variation, so it can over-predict because of the presence of a mucosal scab or food residue or blood. There could be over-prediction of injury. And obviously, these are operator dependent. So one may say that it is low grade, the other could say that it is high grade. And obviously, there are other limitations like you can assess only esophagus and stomach. And if a patient is presenting late, you try to defer the endoscopy or try to avoid the endoscopy. And whenever there are advanced injury, endoscopy cannot be done in the distal part, and whenever respiratory distress or unstable, these are the different limitations of this endoscopy. However, a few limitations can be tackled with the other modalities, that is the relook endoscopy. So what is relook endoscopy? So relook endoscopy, you redo an endoscopy after 3 to 5 days, and then you see what is the actual grade. So this was the paper which was published from PGIMER only, and which showed that compared to day 1, the day 5 endoscopy was a better predictor of actual necrosis or ulceration, those are present, and it was a better predictor of subsequent stricture formation. So that's why there is a concept that relook endoscopy can be done in these patients. However, the low grade injuries patient does not require relook endoscopy. It is only a subgroup, that is patient who are having initially high grade injury, which may be considered for relook endoscopy to identify the actual amount of damage. So these are the few images where you can see on day 1 endoscopy, you can see there is circumferential ulceration, which some may report as 2B injury. However, on day 5, you can see mucosa is completely normal except some amount of hyperemia, and you will grade it as only 2 and only as grade 1. And similarly, if you'll see one of the patient where extensive black charring you can see on the in the stomach, while when the endoscopy was repeated on day 5, it was just a circumferential ulceration and not the complete necrosis of the GI tract. So that's why a relook endoscopy can be considered. Then moving to the next part, that is the CT in acute caustic injury. So the first question is why a CT is required? What is the protocol? We will be discussing what is the grading system and who requires actually CT. So just looking at the case, that's a 47-year male with accidental ingestion of H2SO4 fatty acid. And when he presented to us was in dyspnea. And on day 3, when he presented to us was having tachycardia, tachypnea, ALI and AKI, both were there. And obviously endoscopy could not be done. So what is the next step? How could we identify the amount of damage? And that is very important because doing surgery itself may be risky in this patient. So we got a CT done in this patient, and you can see there was a complete non-enhancement of the stomach. And intra finding, you can see there was a fundus was showing complete necrosis. So that's why CT is important in certain patients. We will be discussing in which patient we should do. So there are 2 protocols which worldwide people have followed or people have given. So protocol 1 is you initially do a non-contrast CT and you see the presence of any air in the vicinity of GI tract. If there is no air, you go with the CT with intravenous contrast, but without oral contrast to look at the grade of CT grade of injury. But if there is air, you should give the positive oral contrast also to identify the exact site of perforation. And the second protocol is you just do a CT with intravenous contrast and no oral contrast should be given in this patient. So there are two grading. One is Ryu grading, which nowadays no one uses. It is an older grading. And the second grading is Chirika grading. So Chirika is the most simplified. However, there is a lot of similarity between these two grading that both talks about the wall thickness, the peri-organ soft tissue infiltration. However, the third important point is in the Chirika grading is wall enhancement. So based on that, they decide whether it is grade 1, 2, or 3. So it is one of the few examples of Ryu grading, where you can see grade 1 is normal esophagus, grade 2 is there is thickening of esophagus. However, there is no peri-organ infiltration, while in grade 3 there is thickening as well as there is peri-organ infiltration. And while in grade 4, apart from thickening, the interface with the other organs are also lost. While we talk of Chirika, the grade 1 is a normal esophagus or stomach. The grade 2 is when there is thickening. The serosa is enhancing as well as the mucosa is hyperenhancing. So this is what we call grade 2. And grade 3, when there is complete necrosis and apart from thickening, there is no enhancement of whole of the GI tract. So this is what we call Chirika grade 3. And this actually predict the presence of complete necrosis, transmural necrosis. Similarly, for the esophagus, you can see the different grades of Chirika. So the benefit of CT in doing in acute caustic is that this is one of the study from the France where they showed that the use of CT actually reduces the digestive resection by clearly identifying the actual necrosis. And obviously, similarly, the esophagectomy rates also reduce, and the extensive resection, which sometimes based on the endoscopy people used to do, also reduces to some extent. And obviously, these are the benefits of using a CT. But what is important that they say, the France group say that CT should be done in all the patients and it should be used as a first line investigation. So is it so? If you'll see two of the largest studies, two of the largest database studies, so most of these patients actually have low grade injury, which are neither at risk for complication in hospital or for long-term complications. So doing CT in these patients will just be unnecessary with risk of radiation exposure, obviously. So based on this data, most of the recent papers suggest that CT should be considered in these patients who are having on initial endoscopy 3B injury, that is necrosis on endoscopy, to truly identify the necrosis and to subsequently decide the management for these patients. And if you'll see, these are the recent ISG guidelines which are in the publication stage, which also suggested that CT chest with abdomen should be done when there is high clinical suspicion or signs of mediastinitis or peritonism to assess the transmural necrosis in grade 3B injury on endoscopy and in patients who cannot undergo endoscopic examination because of any reason. And if you want to assess the GI tract beyond the stomach, these are the various indications where you should perform a CT, chest with abdomen. So the question is whether you should consider upfront CT or endoscopy. So just look few of the data, some of the data. So this is the data from the Chirika group where they compared the endoscopy and CT, and they showed that CT identify the necrosis in a very specific manner compared to the endoscopy, or simply we can say that endoscopy over predicts the necrosis compared to the CT. And if you decide your management protocol based on the CT or endoscopy, if you will be using only CT, you will be unnecessarily doing esophagectomy in 20 patients out of 115 patients in this group, and exploratory laparotomy will be done in 23 patients. However, these can be restricted if you use CT with or without endoscopy. So that's why they suggested that CT should be used. However, another study showed that CT is less sensitive, though it is more specific in predicting the short-term outcome, that is the need of emergency laparotomy or death. So the small ulcers or superficial ulcers, CT will miss. So obviously CT is more specific but less sensitive, and endoscopy is more sensitive. So if you compare, both have their own limitations as well as benefits. like endoscopy is easily available at most of the center. It can be used for Zerger grading if you are planning to give steroid therapy. These are the benefit of the endoscopy, and apart from that, it facilitates the insertion of feeding tube if the grading is very high. The risk of radiation is not there with endoscopy, and it is also valid beyond the 48 hours. If a patient is presenting to you on late day 3, day 7, something, then also you can do a CT scopy, but the validity of CT is not there by this time because most of the studies are done within 48 to 72 hours. And also the grading, a lot of people actually don't know the grading of the CT which should be used or what are the various grading available. So these are the various benefit and limitations of using the endoscopy and CT. So CT actually complement and it does not replace the existing endoscopic grading. However, the additional benefit of doing a CT that it can identify certain additional things apart from GI tract, like you can identify the perforation, you can identify the tracheoesophageal fistula, you can identify the pleural fistula, though rare but can develop in the severe caustic ingestion. You can identify the pulmonary infiltrate, the luminal perforation, like this is one of the RT you can see going into the pararenal space. And similarly, you can identify the jejunal necrosis whenever the injury is going beyond the stomach. So if you have to summarize between these two, endoscopy and CT, so endoscopy are more sensitive, identify most of the GI tract injury. CT will obviously won't identify the smaller or low grade injuries, but will be very specific to identify the non-viable tissue, that is a complete necrosis of the or transmural necrosis of the GI tract. But additionally, it also identifies the extra GIT findings, which we cannot see on endoscopy. So this is the algorithm. If you want to manage the whenever a patient is coming of acute caustic injury, you should assess the patient clinically. Fluid and electrolyte should be managed accordingly. Then carefully look for any complications. And if a patient is hemodynamically unstable or signs of mediastinitis or perforation, and look for free air on X-ray or chest or abdomen. If none of these are there, you go ahead with the endoscopy to see the extent or severity of injury. If the patient is having Zerger grade 3B, you do a CECT chest and abdomen to identify the true necrosis. However, if the injury is from 0 to 2B, then the management can be 0 to 3A, the management can be conservative and you don't need CT in all these patients unless the patient is worsening. However, if any of these three features are present in any patient, a CT should be done upfront without waiting or doing an endoscopy. If there are evidences of perforation, patient should be subjected for surgery upfront. However, if there is no perforation and the CT is showing grade 1 or 2, then endoscopy should be done to truly identify the extent of necrosis and to truly identify the extent of injury in the form of ulcer, and to decide whether the patient can be discharged if the patient is having low grade injury or whether the patient needs admission. However, if the patient is having grade 3 injury on CT, these are patients with complete necrosis and these patients should not be discharged. So to summarize, the initial evaluation in caustic injury is based on both clinical and imaging criteria. A single investigation does not solve all the puzzles. The role of upper GI and CT is actually complementary. Upper GI endoscopy should be done in all the patients who are stable. However, a CT is required or to be done in few patients who are having suspicion of perforation, having full thickness necrosis, or when the decision of emergency endoscopy to be done based on the necrosis on upper GI endoscopy, where before taking for surgery, a CT can be done. So with this, I sum up my slides and the talk. Thank you for giving me this opportunity.
Yeah, thank you, Dr. Anupam, for comprehensively discussing on the topic.
Thank you.
So I can't see
Oh,
Dr.
Vikas.
Dash joining. Yeah, hi, Dr. Dash. Sir.
I'm extremely sorry. Actually, since the very beginning, I'm trying to connect through the old link which sir had sent, and it was taking me to the YouTube all the time.
Okay,
So
okay,
now,
okay.
now I have found the the Zoom link. Actually, I was supposed to start the proceeding. Thank you. You have started it on time. I think I had prepared a introductory slide presentation, which I think I'll take it to tomorrow, and then I'll continue from there. Otherwise, the flow will be lost. So, Anupam, thank you very much. That was a very nice, lucid, and comprehensive presentation. And it was looking very authoritative also. This was because I think most of us do not know that you have been the first author of the first guideline that covers the all aspects of corrosive injuries, acute and chronic, that we have been a part of, which is just concluded few months back. It has been accepted, and
Yes.
I think, is it published or just accepted?
No, sir. There are few things left, so it will be published in maybe 1-2 weeks, maybe. Yes.
So I presume there was only one guideline from Europe, but it was not complete, and this is
Yes, sir.
this is complete in all aspects. So we
Yeah, this
look
was
forward to that.
complete.
Yeah, that's a good news, Vikas.
Yeah, I
So
know.
you also are no less in forming the guidelines, and we have been associated with corrosive injury discussions since long time, starting from when we went to Lima with Dr. Kapoor. So you have a lot of experience. So I would request you to continue with the most critical part of management of acute corrosive injury, that is the medical as well as surgical. You are taking two parts at the same time. You may take a little bit more time, no problem. We have time for that. Please continue.
Yeah. Thank you, Dr. Dash, for this. And thanks to Dr. Kapoor for giving us an opportunity to speak in this forum. So my topic for today will be management of acute corrosive injury. It will encompass medical and surgical aspect. There will be some overlap with the previous speakers. I mean, because based on the pathophysiology and based on the imaging and endoscopic findings, the management will be planned. So again, this is just a repetition that ingestion is the corrosive ingestion. Corrosive ingestion is what we are discussing about. And if we see the problem in India, it is constituting about 15% of the problem and about 10% of the mortality. And this problem is not only in India, this is a global problem across the globe. In most of the countries, corrosive injuries have been reported. And problem is that in India, there is a lot of underreporting, easy availability, lack of regulatory practices. And in pediatric population, it is usually ingestion out of curiosity, and in adult population, suicidal intention. This has all been covered, so I'm skipping these slides. So agents. So the management involves multidisciplinary team. First and the foremost is the emergency care physician who will receive the patient. Then comes the role of surgeon, anesthetist, gastroenterologist, radiologist, otorhinolaryngologist, and psychiatrist to to evaluate these patients, because there are multiple problems. Patients can have multiple issues in this managing these patients. So again, this is again, the severity of injury has to be assessed at the beginning. So first and the foremost, as Dr. Harindra has told, history taking is very important. We should know how much is the how much concentration of the acid is used, because very concentrated acid, sometimes patient will vomit out immediately, and dilute acid, sometimes they will gulp in larger quantity, and it can cause slow damage. And liquidity and viscosity of the corrosive agent is very important. Duration of exposure is important, and this is again a animal model where they have shown exposure with the alkali agent. As the concentration of the alkali is increasing, the depth of penetration of the corrosive substance is increasing. And at a concentration of 22%, it takes 10 seconds for esophageal necrosis, and at a concentration of 30%, it takes about only 1 second for to development of esophageal necrosis. So if we see pathophysiology, both the speakers have discussed it previously. So basic pathophysiology, what we are looking at is thrombosis of the vessel, and which causes ischemia and perforation, potential complication of perforation and bleeding in these patients. But again, if we see the pathophysiology, thrombosis is important. Once the ulceration is formed, there is bacterial invasion, inflammation, development of granulation tissue, and so on. I will not go into the detail of this. And in acute phase, if we see the pathology, it is more of edema, inflammation, and thrombosis. And this is the study which was recently published from our institution, and where they have shown that patients presenting in less than 7 days, they have a higher rate of vascular thrombosis in both in the esophagus and in the stomach, compared to the patients who are presenting, whose specimen was evaluated late. That means that vascular complication happening in corrosive is a harbinger of need for surgical intervention, as it has been shown previously also. So this is again the timeline, how the stricture develops, and where we need to differentiate that alkali causes more of liquefactive necrosis, and alkali, being more solid in nature, tends to stick to the esophageal wall, and it can cause more penetration of the corrosive substance, and it can cause more likelihood of perforation, compared to acid, which causes coagulation necrosis, which forms a eschar and a protective layer. But the problem with acid is that whenever acid is ingested, there will be reflex pylorospasm of the stomach, which will increase the extent of injury in the stomach. So it's a very common saying that alkali licks the esophagus while acid bites the stomach. However, when the ingestion of corrosive substance is massive, then the extent of damage is irrespective of the nature of corrosive ingested. And this is again to differentiate the extent of injury based on acid and alkali ingestion. So as we have seen that patient can present with respiratory symptoms, digestive symptoms, and the patient can have emesis of tissue, blood, or coffee ground emesis, mediastinitis, and peritonitis. All these symptoms should be looked for. And it has been seen that if a patient has got more than 2 symptoms, as Anupam has clearly mentioned, many classification, many prognostic indicators have been has been proposed, but none of them is foolproof. None of them is very comprehensive to predict the development of complications. And it has been seen that even asymptomatic patients can bear 12% of the asymptomatic patients can bear esophageal injury. So when corrosive ingestion history is there, so it is mandatorily important to observe these patients and do an endoscopy at the earliest. So this is risk stratification. This is what Anupam was also referring to, the RIGO classification. And here they are looked into the parameters: age, type of corrosive substance, leukocytosis, degree of grade of injury of the esophagus of the GI tract. And again, when the score is more than 14, there is 90% mortality. So one has to be very much onto a lookout whether these patients with high scores, they should be immediately shifted to ICU and managed there only. And again, second important thing in corrosive is, as 3B injury is, suppose 3A and 3B injury both should be monitored very closely, because there can be progress of injury, because what initial endoscopy showing 3A, it can progress to 3B also, or it may regress to 2A, it can go back, and that is the importance of doing a relook endoscopic 3-4 days down the line. And second important symptom is hematemesis and melena, and need of blood transfusion in these patients. If these arises, they are carry a very high odds ratio of developing a complication and mortality. So these patients should not be ignored, and even a slightest bleed should be taken very carefully, and CT angio should be done in these patients. Again, lab derangements can determine the severity, but they have poor correlation. Basically, lab derangements can be a marker of sepsis and SIRS in the form of elevated TLC and CRP, and markers of reduced perfusion, that is elevated lactate levels, reduced bicarbonate, acidosis, and base deficit. So these parameters should always be looked for. whenever whenever a emergency care physician receives a corrosive patient, he should look for all the respiratory symptoms. Respiratory distress and airway obstruction is very common in these patients, because when a corrosive is being ingested, some of it gets aspirated and causes mucosal edema of the laryngeal inlet, which can cause respiratory distress, and involvement of the larynx and epiglottis can happen. And sometimes if the corrosive is aspirated, it can cause erosion of the airway tract, and because the posterior membranous trachea is very thin, and it can be very vulnerable to even a small amount of corrosive ingestion. So these patients should be intubated. If there is respiratory distress, these patients should be intubated or tracheostomy should be done. But whatever is to be done, it has to be done under direct vision. No blind intubation should be done in these patients, because going blindly in these patients will always missing the larynx and going into the pharyngeal wall can make these patients more vulnerable to development of perforation in these patients. Esophagoscopy, Dr. Anupam has discussed thoroughly, but what I will like to emphasize here is that there are contraindication is whenever there is radiological evidence of perforation as seen on CT scan or X-ray abdomen, supraglottic and epiglottic burns and edema extensive is there, because in that case airway management will take the priority, and once the patient is stabilized, then only we should embark on doing endoscopy. And severe injury of the hypopharynx, when these are the few contraindication, I will not say absolute contraindication, but these will be a word of caution for doing endoscopy in these patients. And grading has also already been discussed, I will not touch into this, but the prognostication of the grading, that development of complication as the severity grade is increasing, development of early and late complications is increasing. And if we see majority of the deaths occurring in these patients are those with grade 3B injury, as has been identified. But fallacies of grading system, as Dr. Anupam has also mentioned about it, that charring and mucosal bridges, presence of blood clots can obscure the view, presence of pseudomembrane, use of antacid, bile reflux prior to referral, and overstaging and understaging is also assessed. But again, the problem with endoscopy is it is only mucosal assessment. It cannot assess the full thickness of the GI tract. So relook endoscopy is required. So this is what the paper Anupam was also quoting about it, that relook endoscopy can better predict the long-term outcome of the development of esophageal and antral stricture in these patients. So CT grading, again, it has been discussed, and what we can see here is the development of allied signs, the development of pleural effusion, non-enhancement of the esophageal wall. So these are the particular signs which we should be always looking at. Again, the same picture what Anupam has shown, non-enhancement of the stomach, non-enhancement of the esophagus. So these are the patients where we should not wait, where we should immediately take these patients for emergency surgical exploration. So management, hospitalization of all the patients is mandatory. Hemodynamic stability should be ensured. Airway adequacy should be maintained. So blind intubation should be avoided. Surgical access in the form of tracheostomy should be done whenever necessary. And patient should be kept NPO till they have been evaluated. So once they have been evaluated, then we can decide on starting orals depending upon the grade of injury. So there are few don'ts which should never be done in patients with corrosive injury. Number one is to induce emesis, because inducing emesis or doing a gastric lavage will, both these mechanisms will re-expose the GI tract to the acid or the corrosive substance which an individual has ingested. Second is use of neutralizing agent, because neutralizing agent will cause a lot of exothermic reaction, heat production, and lot of air production. So in a GI tract which has already been exposed to corrosive agent, this can be potential cause for perforation, development of perforation. And use of milk and charcoal should be avoided, because it will always obscure the view for further endoscopic assessment. These systemic steroids, proton pump inhibitors, and broad spectrum antibiotics are controversial. Again, the use of broad spectrum antibiotics should only be restricted to higher grade injuries 3A and 3B and should not be used indiscriminately for a lower grade injuries. And development of perforation, mediastinitis should always be covered with broad spectrum antibiotic. So again, this is the sequelae of corrosive injury, so I will not go into the detail. So what is the role of surgeon? Conservative management, when we are embarking on the conservative management, how long we should wait, when should we intervene, what are the options, whether to resect or to divert, and can we do emergency reconstruction in emergency settings? So as we know that grade 1 and 2, they can be suitable for early discharge. Grade 2B and 3A, they are managed conservatively, and in these patients, one should be very careful that we should be able to establish a nasoenteral feeding in all these patients, because if a patient is not able to take orally adequately, we need to put nasoenteral feeding. If a patient, because these patients are likely to develop long-term stricture and complication, and if there is a hypopharyngeal stricture, if there is a tight stricture in the upper esophagus, then it will further in future preclude the placement of a enteral feeding tube. And all grade 3B injuries should be monitored in the ICU and should be considered for early surgery, because we have seen perforations, delayed perforations as late as beyond 2 weeks also. So all deaths and perforations occur in grade 3B injury. So this has to be corroborated with the CT findings in the form of non-enhancement of the GI tract, and this mandates early surgical intervention. And grade 3A injury, again, we should, in relook endoscopy, we should ascertain that there is no progression of 3A to 3B. If there is progression of 3A to 3B, it should be managed with, it should be immediately subjected to CT evaluation and managed accordingly. So this is the radiology. Again, we can see the air under diaphragm, evidence of perforation of the stomach. We can see air in the mediastinum. This is pneumomediastinum, and this is a sequelae of esophageal perforation. And along with that, we can see some amount of pleural effusion is there. And intractable bleeding. When the bleeding is massive and intractable, there can be a suspicion of erosion of the corrosive into the major blood vessel. That suspicion should always be there, and it should always be ruled out before we are contemplating any other treatment. And persistent acidosis, again, that is a harbinger of indirect evidence of ongoing necrosis going on in these patients. So these patients should not be left unattended. They should be taken up early for surgery. Presence of organ failure is again a very ominous sign, because presence of organ failure is a major predictor of mortality in these patients. And grade 3B injury, again, I will be coming again into 3B injuries. And again, this is again one CT scan of a patient where we can see a lot of air in the posterior mediastinum and development of pleural effusion to suggest esophageal perforation. And based on the CT findings, the algorithm has been proposed that in grade 1 and 2, they can be managed conservatively, and grade 3, they should be referred for emergency surgery, because these are non-enhancing, and these are avascular, these are ischemic GI tract, and should be removed as early as possible. So this is what we published last year only, that we published our experience of about 15 years cases. So in the initial period, we used to wait and watch when these guidelines were not there. And in 9 cases, we observed a 69% mortality in 3B patients. However, in the later cases, subsequent in the later 7-8 years, we found 11 cases of 3B injury, and we took them for upfront surgery, and the mortality decreased to 36%. So in view of all this, we will advocate performing early surgery in all 3B cases. So what are the principles of surgery? Is to extirpate, total extirpation of the dead and devitalized tissue. Simple closure of perforation is not suitable. One should make every effort to establish an enteral feeding line, look for the extent of damage, and we can extend the resection as required. preserve the length of esophagus because it will be required for future reconstruction. And as a policy matter, there are some reports of doing reconstruction in acute setting, but as a policy matter, we usually do avoid doing a definitive reconstruction in the acute setting because we always see that the corrosive substance has been ingested. There has been a single insult of the entire GI tract, so we don't know what is healthy and what is unhealthy till the scarring and cicatrization has completely occurred. So we try to avoid doing a reconstruction in acute setting. So involvement of trachea is an indication of early intervention. So early intervention, by that I don't mean that doing an emergency intervention, but again, involvement of trachea whenever is there, we should try to operate upon these patients maybe in next 3-4 weeks time, because these patients will be prone to recurrent aspiration, and stenting sometimes is not feasible. Most of the time will not be feasible in these patients because of the underlying stricture and underlying diseased esophagus, which any endoscopist will be reluctant to put a stent in the acute setting. And based on the length of the stricture, we can tailor the management of the tracheoesophageal fistula. So this is what we published some time back only, that we found cases with tracheoesophageal fistula, and when there is a short segment stricture, particularly this happens when there is aluminum, low grade aluminum phosphide poisoning, or button battery type of poisoning. So that it causes a localized damage to the esophagus. So that is what we classified as type 1 fistula, where there was a short segment of the short segment esophageal stricture was there, and it could be managed by end-to-end anastomosis. However, when a long segment is there, we always dismantle the fistula. We keep some esophageal tissue over the fistula for the closure, and we buttress the tracheoesophageal fistula with pleural flap or with the intercostal muscle flap. And when replacement is required, we do a colonic interposition, or subsequently that can be done in the anterior mediastinal route. This is a case report what I have taken from the some of the journal. This is a rare event where due to the button battery injection by a child, there is massive hematemesis, and the corrosive has eroded the aorta, and this is a aortoesophageal fistula which required urgent surgery, and this is associated with a very high mortality. So what should be what surgical procedure should be done? There are two types of surgical procedure which can be performed. One is exclusion procedure. Second is ablation of the GI tract. So pros of the exclusion procedure is that exclusion means that we are patient is having a mediastinitis and perforation of the esophagus, and then we are doing esophagostomy and gastrostomy and feeding jejunostomy as exclusion procedure. But again, this is a safer procedure, involves less blood loss, can be performed in an unstable moribund patient, can be performed quickly. However, the problem with this procedure is the completeness of source control will remain questionable, because there will be some amount of ongoing contamination, because we are not occluding the GE junction in these patients. Completeness of diversion is sometimes questionable, and we have seen that many times esophagostomy has been done and it goes down into the surgical wound, and the diversion fails sometimes, and underlying esophagus is diseased, and this can lead to ongoing sepsis, and the patient outcome can be worsened. However, ablative procedure, again, these are complex procedure. They are extensive procedure, will require more blood loss, more operative time, and has to be done with an experienced surgeon. But they have the advantage of doing a complete source control, doing a complete diversion, and addressing the underlying disease esophagus. And this is what we published last year only, that the resectional procedures and non-resectional procedures can be done. But the problem is that whatever we do, we are doing surgical procedure in these patients, the mortality rate is very high, and this has been high mortality is observed across all the studies which have been published so far. And this is just an example to show a total gastric necrosis, which patient underwent total gastrectomy and esophageal stump was closed. But the problem of closing the esophageal stump in acute setting is that the esophagus is also diseased. So the stump can blow out, number one. And if stump will blow out if we are not doing a diversion esophagostomy, or we are putting a tube in the esophagus to divert the esophageal secretions. saliva and esophageal secretions. And second problem with these patients is closing the esophagus, or not, just closing the esophagus in the near the G junction, is that subsequently this G junction is very difficult to find out during the reconstructive surgery, and many times we resorted to doing anterior mediastinal bypass in the neck rather than being able to find the esophagus in the abdomen and able to do the reconstruction there. And esophagogastrostomy, gastric necrosis, we always do esophagogastrectomy and a feeding jejunostomy. Then the second problem which comes after esophagogastrectomy is the management of the duodenal stump. So initially, in the initial part of our this thing experience, we used to staple close the duodenal stump and reinforce with a suture. But we found that 4 out of 3 blowouts occurred, and all the blowouts then required re-exploration. And these patients who are already moribund, the blowout acts as a second hit, and this eventually results in mortality of this patient. And subsequently, we changed our practice from closing the duodenum stump to doing a tube duodenostomy, which worked well, and there was no peritubal leak. And because these patients, apparently the duodenum and the duodenal stump looks healthy, but when we are closing, because they have a lot of systemic inflammation, SIRS, sepsis going on, so these suture lines sometimes they give way. So that is the reason we always try to do a definitive reconstruction, always try to avoid doing a definitive reconstruction in acute setting. So how to manage? Second problem is how to manage the esophageal stump. So what we can see here is the esophagus has been exposed in the neck, and a long stump has been kept of the esophagus, and this stump is brought out from the subcutaneous tissue onto the chest wall. Although we keep some amount of diseased esophagus, we bring out the diseased esophageal stump on the chest wall, and we keep this stump patent with using a nasogastric tube into the this cervical esophagus. How this helps in subsequent reconstruction, because if we are just making the esophagostomy close to the neck, the number one, the stump length of the stump will be short, and it will be difficult to manage, because in the mobile neck it will be very difficult to apply a stoma bag, and it becomes a real mess to manage these. And secondly, thirdly, and sometimes if this stump retracts down, it becomes a kind of a salivary fistula from the neck, and this keeps on contaminating, some amount of contamination of the mediastinum, and patient will keep on aspirating saliva at times. So this is again a patient with combined esophageal and a gastric perforation. Here we have done a total esophagogastrectomy, and the perforation was delayed, and small perforations, the viscera is, even if the perforation is small, it is advocated to do a formal resection of the viscera, because the viscera is diseased, thinned out, and the closures are invariably insecure. And gastrotomy, surgical intervention in bleeding, we have seen bleeding from the stomach, we can do a gastrotomy, evacuate the clots, and the hollow thin out viscera is not suitable for closure, so we have to do a resection in these patients. And sometimes we have seen that the corrosive extent of corrosive, extent of injury extends beyond the pylorus. And in these situations, in the second stage, this patient had undergone enteroduodenectomy, and in the first stage, partial gastrectomy was done. And in this patient, again, very extensive corrosive injury, total ablation of the foregut was done, esophagogastrectomy along with the complete duodenectomy. And in this situation, what we do is we manage the pancreatic stump with putting tubes into the pancreatic and bile duct, and this pancreatic juice and bile juice is subsequently fed through the feeding jejunostomy tube. And sometimes we have seen, because of the systemic effect of corrosive injury, the necrosis and inflammation can extend well beyond the stomach and esophagus. They can involve the contiguous involvement of the colon, spleen, and even development of pancreatitis has also been reported and seen by us. This is a patient where involvement of spleen was there, and we did a esophagogastrectomy with a splenectomy. So concomitant duodenectomy I have discussed earlier also. So the problem in emergency surgery is because the patient is very much compromised, he's very moribund, and the mortality is high. And the major predictor what we have found is the presence of organ failure at the time of admission. However, the timing and nature of surgery did not make much of difference. Was not found to be different in patients who are surviving and non-surviving. Probably this was because the sample size was very small in this patient. You will not get so many patients except for the CHIRCA study. There are not much studies where they have substantial number of patients undergoing surgical resection in acute phase. And follow up in these patients, when we see that these patients have to be maintained on tube feeding, and they are prone for recurrent aspirations because many of them will develop pharyngeal strictures. And if we see the literature, about 30% will not be able to undergo a definitive reconstruction because of the one reason or the other. And this is the reported literature in the world, where we can see mortality as high as 82%, 50%, 41%, 45% has been reported in the setting of acute corrosive injury. So this is the algorithm, I think, which we have, and Dr. Anupam has also discussed very clearly that in case of 3B injuries, it is, low grade injury, first grade injury, we can observe for 24 to 48 hours and then we can discharge. Grade 2 and grade 3 injuries, they are to be managed with IV fluid and NPO. Grade 3 injury should be re-evaluated for development of subsequent complication or progression of the complication. And in case of 3B injury, it is, and 3B injury along with presence of ischemia as evidenced on CT scan, they should be taken up for emergency resection. So to conclude, I will like to say that corrosive ingestion is a common problem. Early endoscopy and stratification is mandatory. CT scan can also add to the information of endoscopy. Grade 3 on CT and 3B on endoscopy should be very carefully watched, and they should be taken for surgery, early surgery. We should always be looking for perforation and mediastinitis. Organ failure is a very bad news, poor determinant of outcome, and early surgery and resection procedure with preservation of length of the esophagus should be preferred. Despite everything, the mortality remains high, and it needs a multidisciplinary approach to manage these patients. Thank you very much for your kind attention.
Thank you, Vikas. That was a clear, complete, but comprehensive.
Sir.
That's to interrupt, because I'm in a train, I will lose my connection. So I will just put some questions on behalf of this, and then.
So you are not clearly audible. Can you message that? I will cover up in the discussion.
Try. Otherwise tomorrow.
No, it's not at all clear. We can't hear you, sir. It's interrupting.
Please.
Sir, please message. Please WhatsApp me. I will cover all of them in the open discussion. So actually, sir is in flight. We can't hear him very clearly. So in the meantime, if he is clearly audible, he would like to ask some questions, and we will like to answer that. So because that was a very clear, comprehensive A to Z discussion on the medical as well as surgical management of acute corrosive injuries.
Yeah.
I think you would agree with me that the management proper, the treatment proper is not so difficult or extensive. There are very few specified steps that you have to follow. It's the decision making that is confusing, and at times they are really confusing to take, isn't it?
Yeah, I will fully agree with it, because it is not a one-time assessment. You need to have multiple assessments of these patients. You have to be on a lookout. These patients have to be very intensively monitored.
Yes.
So, because I remember a case. Dr. Kocher was at that time in PGI only. So what happened was, there was a 3A guy. He was, he said 3A, so we admitted him. So we observed him. We observed him for almost 2 weeks. Nothing happened, and then we discharged him after with nasogastric tube. And 3 days down the line, he came back with peritonitis, generalized peritonitis, and there was big perforation in the stomach. So, it's really very difficult. I mean, it's not, I mean, 1 + 1 is equal to 2. It's not like that kind of a situation.
Yeah, from the very beginning, the patient enters to the hospital for the first time till he is discharged from the acute stage. It's all in every step. There is a difficulty in taking a decision. So, experience is so important, and exactly we don't have very strong evidence to really, or a guideline to really tell us if this is the condition, then we must do this. There are confusions and debates also, including the eschar formation, which was earlier said that the eschar formation because of the acid, it occurs within 72 hours. So that's the best period to do endoscopy. Now this is also being debated. Professor Anant Krishan's group says that I've heard him somewhere, he was speaking that the early endoscopy actually it was insurance guided in Western countries, that if you admit these guys early and do endoscopy early, so you can discharge them early, saying that the injury is not severe. So the confusions or the controversies, they do remain. Now, if you agree, because then we can start the open house discussion. Let us start. We have some prepared questions, and certain questions I just gathered from your and all of our presentations. So let's try to answer them. And in the meantime, we'll include Dr. Kapoor's questions. So till we get some questions on the chat box, can I start some questions, Vikas?
That's excited now.
Because are you able to hear Dr. Kapoor?
Yeah, sorry. Yeah, sorry for the interruption. Yeah.
Can you hear Dr. Kapoor?
Yeah, I can. Okay.
So if you can hear his questions, you can just ask those questions. Actually, I am getting only interrupted voice. I think his message has come to continue.
Yeah, okay.
So let me start the journey from the very beginning. Once the patient comes to the OPD, is just struck to me at this point of time. It's question for Harindra. Harindra, are you there? Yes. Harindra, would you unmute? Yeah. The first
Yes,
thing,
sir.
the
I have
first
unmuted.
thing, mostly in tertiary care institutes, we used to get patients when they have been managed in the primary healthcare centers, isn't it? So
Yes.
once the patient gets into the OPD, what about the status of the MLC, medical legal situation? What should one do? Anyone
Sir,
who has experience can answer.
we should assess the medical legal aspect of the.
What to do immediately? Go for the management, inform the police. What is the way to go about it?
Sir, we should do the MLC, and I think we should start managing the patient.
And what do you write on the MLC book? Your thought about cause of the, you go by the parents, the attendants, what they say, or what you think?
Sir, we can write, sir, right. We can write the history of alleged history of any acidic or any corrosive injury. Alleged history of any corrosive injury, we can write alleged history of corrosive injury, and we can start up the management protocol.
And
I think,
Doctor,
Can I interrupt? Can I interrupt? I think what you have raised a point, medical legal is a very important thing. So first of all, we should be recording
Yes,
that
sir.
who are the accompaniments of the patients, number one. Secondly, if a patient is able to tell the exact scenario, I mean, patient is able to give the history properly. And secondly, I mean, we should be assessing the conscious status of the patient. So these two are very important at the initial assessment. Then third is the history is reported by whom? By the patient himself, or it is reported by the accompanied person. So, and then fourthly, any first degree relative of the patient is along with him or not. So if a patient is not able to give the history, then the reliability of history is very questionable. And if a patient is himself giving the history and patient conscious status is alert, so these things should be recorded very clearly in the by the emergency physician, and then I mean at simultaneously treatment should be started, because many times patients will have respiratory distress, respiratory distress, and they will require intubation. You might not be able to get a proper history from these patients.
And corollary to that, actually, when we are at the tertiary center, we get a patient, we get after the MLC has been filed by the primary healthcare center. So when the patient comes to us, should we again inform the police, or what should we do?
Can I,
Anupam.
sir? So
Anupam, yes,
actually,
yes.
I had a discussion regarding this point to one of my forensic colleague on one of the cases. So first of all, there are a few things which sir have already told, that how the history should be reported on record should be maintained adequately. The important thing is regarding the making MLC or not. So in government hospitals, all government hospital, it is mandatory to make it MLC, first of all. So whenever a patient is coming to you, when you are sitting in a tertiary care, the MLC has already been made at some other place, then you need not to make it again. You just have to write the previous MLC number on the file, but you have to report to the police that this patient we have received, which previously have been done somewhere else, but you need not to make it again MLC. So that is for government hospitals, or whenever you are getting a referral. But as per the forensic, it is not mandatory for the private setup to make the MLC if you are having a if you are having a accidental case. So if you are having an accidental, it is not mandatory, but for all practical purpose, for the all safeguard, people do make it MLC. So if you are not sure what was the reason for ingestion, obviously it is better to make it MLC. But properly, just mentioning that it is MLC, it is better before referring to write the MLC number also, so that to save the subsequent time, whenever a patient then you are referring, it will save a subsequent amount of time in doing all these actually things like making MLC and wasting time, rather than you just write the number and then refer. So this is regarding the MLC. And once a patient has been made MLC and you are readmitting the patient, the same patient you are discharging and then readmitting, so you need not to make it MLC, just write the previous MLC number and inform the police that we have readmitted this previously patient with these complications or these reasons. So you have to inform the police on every admission, but you just have to write the previous MLC number. It is not that every time you have to make it MLC or a new MLC.
Is it advisable for the private sector people, when they get a corrosive injury, to do the primary care and then send the patient positively to the government setup, or they can manage?
No, sir, they can definitely manage. But if they are having suspicion that it is not actually accidental, they have to make it in MLC. They have to inform the police that this is the case we have received. They can definitely manage. There is no if and but that private setup cannot manage. They are having facilities. They have to inform the relatives, family, and they can definitely manage the patient, as any of the tertiary care center is managing, barring the situation that they are having experience to manage these things. But obviously, because if you are not having experience, you are not having enough team, you may be in soup, because maybe later on patient may file a case that you are not equipped enough to manage these cases. So obviously you have to have the sufficient equipment, the expertise, then only you should manage these patients.
Harinder,
Sir.
how is it important to distinguish between a acid poisoning versus alkali poisoning? Is it is it absolutely, is it important to know what he has taken and how does it affect your management?
Before
Sir, alkali poisoning.
Sorry, interrupting. Dr.
Yeah.
Chetan
No, no, no.
Kantharia from
Okay,
Mumbai,
sir.
HOD, GI Surgery, KEM has joined us.
Hello, sir.
Welcome, sir.
Hello, sir. Hello.
Please put your questions, please put your ideas whenever you want.
Yes,
There
sir.
is
Yes,
there is
yes,
there,
sir.
there was suggestion by Dr. Vinay Kapoor that for international students, the full form of MLC is medico-legal this thing case, and it is a kind of medico-legal formality which has to be completed in patients with
Yes.
yeah. Okay, fine.
Okay.
Yeah.
So, Harinder, history of alkali versus acid, how does it affect the management? Yeah, Anupam, you can take if
Yes.
he's.
Sir, alkali causes the liqueficative necrosis, sir.
Yeah,
Alkali
how
causes,
it is important in the management? Is it Anupam?
Okay, so regarding the
and it
alkali
increases.
Mhm.
Oh, I'm asking Anupam because your voice is interrupting. So, Anupam.
So regarding the alkali and acid, so earlier saying was that because the alkali are typically pungent smell, so
Yes,
people
sir.
take it in a small amount only, and typically it only damages the esophagus. But as far as the outcome are concerned, the recent data supports that it does not differ when
Yeah.
you are having or consuming a small or strong acid. So it does not differ. In fact, one of the systematic review in medicine update actually showed that the ingestion of acid itself is a poor predictor as compared to alkali, and the same was showing by Tosca et al. In the endoscopy in 2021, which also showed that in fact acid is much more dangerous. But as far as so for all practical purposes, both should be managed as the continuous evaluation should be same for both. But as far as the penetrating injuries are concerned, it is more with alkali unless you are having strong acid. So that is only differentiate. So if you are having extensive pancreatic involvement, if you are not sure what was the type of acid, corrosive substance that was ingested, you should suspect that it is most likely alkali. So the progression of disease is more likely with the alkali compared to the acid as well. But as far as the outcome is concerned, both have poor outcome.
Yeah, for the students, why acid is coagulative and why alkali is causing a liquefactive one and more damaging. Actually, acid precipitates coagulates the proteins, and alkali acts on the proteins as well as the lipids, which are important components of the cell. So that's why it causes more damage. It is the chemical reaction as well as the heat producing. Alkali produces more heat than acid. So that's a combination of that. Now, second important point before we manage is when to take a psychiatric opinion. Is it at that point of time or when?
So if you will
Either you or Dr. Vikas.
So if you will ask me, sir, most of these patients which we are catering, they try to hide the actual history of suicidal intention. So it is always better to take a psychiatry initial evaluation just to dig more. If you are not able to sure if you can dig more, then you should always take a psychiatry help. But in patients who are less than 18 years, because the chances of suicidal injuries or you should dig out these patients because they are too young for these kind of injuries. So in these patients, you should always take psychiatry opinion, no doubt. But for adult, it is as per your decision whether you want to take a psychiatry help for digging more or not.
Because after that, you want to add something?
Yeah, I just want to add, I mean, at least whenever the patient is stabilized and before the discharge of the patient, this should be done.
Okay, that should be done. No, no, I thought at the initial stage, if you take, we have found, we have done a quality study and psychological study in these patients. We found the initial period, if you do a psychiatric evaluation, you invariably get wrong information.
Yes.
And then as you progress, so it's a multiple setting that is important in these people, not that once they gave their opinion and leave behind the other follow-up, that should not be done. Because oropharyngeal injuries are commonly associated, when to decide whether a endotracheal tube intubation or a Riles tube or a tracheostomy?
Yeah, I mean, we should.
Sir is asking something. Okay, you can continue.
Fine. So I think it is we should do in a patient who has got respiratory distress, we should try to visualize the larynx. If we are able to visualize the larynx and we are able to safely intubate under vision, then orotracheal intubation should be done. Otherwise, if a patient is, if the larynx is very edematous, there is only pinpoint chink hole opening, which is going to be difficult to negotiate, then it's better to do cricothyroidotomy followed by tracheostomy.
Okay. Yeah. If the larynx area is inflamed, then it's the endotracheal tube may be more harmful, isn't it?
Yeah, because
So-
pushing it through the edematous tissues will cause more damage rather than doing a tracheostomy.
So is it that we should have a low threshold in putting a tracheostomy? Because we have seen patients when we discharge early, even at home, they can have asphyxia and deaths.
Yes.
So that has to be remembered.
Mm.
And what about that controversy in Riles tube? Can you settle it once for all?
Riles tube in acute setting should not be done, because this will, I mean, trying to do a lavage and aspirating the contents will again re-expose the ingested corrosive to the GI tract, to the ingested corrosive. So it should not be done.
So how to feed then to these patients?
No, feeding should be once the assessment is complete. Okay. And then we are maybe 3-4 days down the line, then we should see that if it is a lesser grade injury, we are able to start orally to these patients, then it's well and good. If we are not able to feed orally, maybe like 3B, 3A injury or 3B without, I mean, CT evidence of necrosis, not requiring surgery. So in these patients, nasoantral tube should be done. And it is always preferable to do a nasojejunal tube rather than a nasogastric tube, because many patients will subsequently likely to develop this thing, pyloric stricture also.
I will seek your opinion for regarding that feeding jejunostomy part. Before that,
Not
Anupam, how
feeding
to
jejunostomy, nasojejunal.
yeah, we'll also discuss about feeding jejunostomy part. Before that, Anupam, how to decide that this patient will definitely not need a endoscopy, or when to exactly start orally when there are mild varieties of injuries up to 2A. Unmute.
So regarding your first question, just before that, I would like to add on one thing what Vikas sir said, that what you wanted to say is blinded RT. So blinded RT should not be placed in any of the patient. So that is the thing I think that sir wants to convey. For feeding purpose, a guided endoscopy guided feeding tube can be placed safely. So that is what sir I think wanted to say. And regarding the endoscopy, so far there is some data to suggest that few patients don't require endoscopy just based on clinical evaluation or whatever lab data we are having. So so there are three factors which in one of the studies that was published in American Journal of Gastroenterology, that's a large cohort study, where they showed that if the ingestion amount is less than 200 ml, if the pH was so they categorized as a weak or a weak pH or a kind of towards the normal pH value. So between 5 to 7, if the pH is between 5 to 7 or 5 to 9, so that is something low pH or weaker acid or alkali ingestion. And the third, if there are no symptoms, asymptomatic. So if these three criteria are fulfilled, then you typically don't require any of the endoscopy. But this is the only study which have shown other previous studies are having conflicting data, that some suggested that irrespective of symptom or signs, people can have esophageal injury, and that what sir have also showed in one of the paper, that 12% of the patient, even without having any kind of symptom or sign, can have esophageal injury. So for all practical purposes, you should do endoscopy. But if you want to avoid subset, then these are the patient where you are having a small amount of ingestion with a weak acid or alkali with a no sign or symptoms, then you can avoid. But if you are avoiding, you cannot early discharge these patients because these are medical legal cases. You have to monitor them till the patient can be started orally. So once they are able to take orally, then only they can be discharged. The
So
second
when to start orally
yes, sir.
in
That is the
grade
next
1,
question.
grade 2,
Yes,
grade
sir.
3?
So
When to start orally?
yes, so that is the next question I'm coming. So regarding that, there is one study which was done by Dr. Koche where they categorize the patient into low grade and high grade. So low grade means less than 2A injury, 2A or equal to. So in this patient, you just have to wait till the patient can take orally. I mean to say till the time dysphagia improves or subsides, you can start them orally by that time. So in that study, they started as early as 48 hours. So if after 48 hours the symptom improved, they start him orally and then they discharge. And then second, depending on the grade of injury, if the grade of injury is 2B on 3A, then ideally these patients should not be started at least for 1 to 2 weeks. This is what has been recommended by most of the authors. And one author from I think from one of the third countries, Ashish Chiba, I think, Abhinav Chibia. So that paper also showed that in these patients, nutritional support is required because these patients are in catabolic state. So either you should do a feeding jejunostomy or an additional NJ should be placed, but nasovaginal tube should be placed. But if you want to start orally, the orally should not be started at least for 1 week, because most of these complication perforation can occur within 1 to 2 weeks. So that is the time period where you should ideally observe these patients. Regarding the 3B injury, if the patient is having 3B on endoscopy, and if you confirm that on CT that it is complete, then these are the ideal patient where you should do a feeding jejunostomy for feeding purpose, for nutritional support. And these patients typically should not be started for at least for 2 to 3 weeks orally. And these for this whole time, actually 2 weeks or 3 weeks, these patients typically require monitoring in a hospitalized care or ICU care.
Role of PPIs and sucralfate coating
So that
agents?
is, again, sir, that is regarding the PPI, that is controversial. There are only 2 papers which have showed. One was a case series which showed that you redo a endoscopy after 4 days. So again, after giving an infusion of proton pump inhibitor, and that again contradictory to that, what Dr. Kocher showed, that if you do an endoscopy on day 5 itself, obviously because of the clearance of these mucus, blood, etc., the grading actually reduces by itself. There is no need for PPI. So that was the one paper. The another paper was a RCT. That was a small RCT which was actually just included, I think, around 19 or 17 patients. The problem was it showed that it reduces the esophageal stricture, but it does not reduces the gastric stricture. So how is that possible? The second point, if you are having a gastric injury, so what is the effect of PPI? So PPI, so you know that gastric mucosa is gone, then how the PPI is working, we don't know. So we are not having sufficient data to support that PPI should be given in all these patients. Regarding the sucralfate, the problem with sucralfate, most of the study which have shown benefit, they have given extensive regimen. So what they have done, they have given 10 to 20 ml of sucralfate every 2 hourly. So imagine a situation who is having laryngeal edema with dysphagia or odynophagia. So you are feeding these, so they are at very high risk for aspiration. So why do you want to take that risk? So obviously, if you want to feed these patients or you want to give the syrup in this patient, you have to exclude a group which is having dysphagia, because most of these studies are done in the patient in the initial 72 hours only. So they give extensive regimen of sucralfate in 72 hours. So again, that hinders the use of sucralfate. So we need more studies before we can say that sucralfate is beneficial, because giving these syrups in patient, those who are having dysphagia or dyspnea or laryngeal edema, obviously can make the thing worse rather than any improvement.
Does sucralfate, if it is aspirated, cause damage to the bronchial mucosa? Is there any
So it's not about the sir, because these patients are obviously at high risk for development of lung injuries, and in fact one of the studies showed that aspiration was the most common. So that was from the Taiwan, that aspiration was the most common cause of mortality in these patients. So it is not only the sucralfate aspiration, it is all kind of aspiration which leads to the poor outcome. So I mean to say that you are giving such an extensive drug or syrup, obviously the chance of aspiration increases.
Okay, so we have 24 minutes more to discuss. Because would you like to? I would pause here, and if you want, you can continue with this discussion, and then I will come up with my questions. Harinder, also, if you have questions, you can discuss.
Okay. So
Because you can please start from the FJ issue. That's all.
Yeah,
When to do FJ and what is the.
So I think this question should be directed to you or Dr. Anupam. So when will you like the patient by the feeding disease? He has
Okay,
partially
see,
answered
this
this
has been
question.
a discussion in our scenario here. When to do it? The medicine people
Yeah.
wants us to do it as early as possible.
We
Uh,
always tend to play it. Yeah.
yeah, they see the grade of injury and they say that we don't think that this guy is likely to cause.
Yeah.
And there would be, suppose there are gastric outlet obstructions also, the chance of feeding is very rare. I know Anupam is possibly doing a trial on NJ versus FJ type thing. We had done it in other conditions of the esophagus. Both of them have their own pros and cons, but obviously in certain situations, NJ or nasogastric is not so feasible or even not better tolerated, particularly if there is a nasopharyngeal injury. So in our scenario, we would like to do a feeding jejunostomy. If our medicine colleagues or gastromedicine people say that get it done, otherwise we continue with IV fluids and TPN in these patients and see when they're maybe a 1 week or 10 days period to see whether this patient is likely to start orally or not. Now, when to do it? Now, we have seen, we are not published, this is our observation, that when we do CT scan and we find in a majority of cases, there is proximal jejunal thickening and edema and inflammation. Now, there we have found technically problematic if we do FJ within 3 weeks period. So means the sutures actually doesn't hold good. If you fix it, the likelihood of detaching it, getting detached from the wall is more. So this is our observation. This not I don't know what is your experience. So we would prefer to do the feeding jejunostomy at 3 weeks time. Until then, we tell them that you manage with TPN and see whether the patient is eligible, or later on endoscopically whether you are able to put a IELTS-2 and see. So what is your opinion?
And how often have you seen this jejunal edema on CT scan in these patients? How frequent is this find?
Our observation says it's about 70%. Proximal 1 feet of the jejunum, where we usually do the feeding jejunostomy, that area is edematous. If we do it within a week or so, so we are almost stopped doing it during the first or mid part of the second week.
Yeah, because what
But I should say that mostly the feeding jejunostomies are also done by the surgical people. I don't have their experience. We have very less of experience, maybe 10 or 12 over the last 10 years.
Okay. In fact, what our policy was to delay the feeding jejunostomy at least beyond 2 weeks, because 2 weeks is a cutoff time when the risk of perforation minimizes. So if a patient is requiring a nutritional support from a tube feeding. And then we always prefer, because doing feeding jejunostomy early and then maybe 4 days later the patient perforates, that means you are doing another trip to the OT, another exploration for the patient. So that's not a good thing to have. So our policy is today, because, but again, categorically, what you have said, I mean, looking at jejunal edema, we have not specifically looked into this finding, and preferable and mostly this feeding jejunostomy is done by a senior resident or a junior resident. So I mean, so they do it, and exact situation is, what is the exact situation is difficult to assess. But again, whenever they do, they always tell that it was not a problematic.
This is our, you can say, our fear,
Yeah,
rather than a scientific observation. So
yeah, that's
yeah,
okay. Yeah.
yeah.
So if it is there, it is worth publishing.
Yes, yes. Mm.
Yes.
So while doing feeding jejunostomy, do you look at the, because we do it, if we do it laparoscopically, it's fine. We can watch the other organs. While doing a
Yeah.
FJ by open technique, we only look at a very limited area. Is it necessary to assess the stomach at that point of time and think of whether we should go for a gastrostomy or not?
Yeah, in fact, usually we always look at the stomach, but again, we are always very scary to make a hole in the stomach beyond, even beyond 22 weeks, because again, the sutures might not hold well in the stomach, even if it is 2 weeks of injury. So we always try to avoid gastrostomy in these patients, because of late what we have seen is most of the antral strictures, they are amenable for dilatation. Because we published about 15 years back surgery in for corrosive injury stomach, and we had around 44 patients in 7 8 years. And after that, we maybe after 2010 onwards, we didn't find much of the patients requiring a total gastrectomy or a partial gastrectomy, because isolated total or partial gastrectomy, because of the antral stricture only. So partial gastrectomy was, whenever was done, it was clubbed with a esophagectomy and a distal gastrectomy in view of antral stricture. But again, isolated antral stricture requiring a partial gastrectomy or Billroth 1 reconstruction has come really down. So we are not much worried about the antral stricture. So gastrostomy is usually, we don't prefer to do a gastrostomy in that setting. We just have a look of the viability of the stomach, and stomach is okay. So that is again kind of reassuring that we are not missing out on anything before discharging the patient.
Okay. Any other question from your
Sir,
side?
regarding the FJ, just I want to add on certain things. So what the protocol I'm following, that in patients who are having initial 3B injuries and CT is also showing. So obviously these are the patients which should be managed extensively. So you manage conservatively with TPN, you wait. If there is no perforation or any complication in the 10 days, then we advocate for FJ. But for those patients who are having 2B or 2A injury, so what we are doing, we are doing a relook endoscopy on day 5. And then based on that, we are deciding. So our usual delay time is between 5 to 8 days. So we are routinely doing in one arm, we are routinely doing FJ by the end of 6 to 8 days. None have shown any complication related to FJ. So this is what my experience is related to this. So it is safe to go ahead with the FJ if the injury is not too high, I mean to say. So you can safely do FJ by the end of week 1.
I will like to differ with this, because regarding complications of FJ, we have seen almost all written and unwritten complications of
No,
FJ.
that
Yeah,
I agree,
that
sir.
is
I
that
agree, sir.
because, yeah, that is because, and secondly, when isolated FJ is being done, it is done by a junior surgeon.
Yes, yes, yes,
So, I mean, you have to take all these things into
yes.
account before advocating any treatment, because we have seen perforation of the tube through the jejunum, we have seen twisting of the FJ, we have seen obstruction, we have seen intussusception, we have seen retrograde intubation. Whatever you can think of it, we have seen
Yes.
all the complications of feeding genostomy.
One of the cases, my final year resident called me, and I saw it was very difficult to invaginate the tube that we do it while doing feeding
Yes, sir.
jejunostomy. Then we cover it with the wall. It was very difficult. It was so tense taking sutures. Maybe that was very anecdotal or so. So I believe Anupam, what he's saying that you can do it early. Um,
In
Anupam,
fact, yeah, my question again, second query. I mean, what kind of FJ you prefer? You will always do a Witzel, or you can do stamps, because sometimes when the bubble edema is there, it's very difficult to invaginate. We have seen patient coming with large Foley's catheter into the jejunum, and made in a stamps fashion to for the feeding purpose.
what is better? Actually, we do always
We
see. I am saying always. This is very little less
Yes.
experience for us, but we do. Would like to do always with gel. We have done, I think, 2 cases or so. But whenever the surgical people, the surgery people, they do laparoscopically, I find it is more of stamp type, and one or two fixations here and there. It's not typical wheat gel where you invert and you take through two on that side, one on this side. They
Yeah.
usually don't do, but we have done in 2 cases.
No, but
There was no
laparoscopically, they
problem.
always,
But
yeah,
only fear is, yeah.
yeah. Because in our preference is also do a Witzel kind of a FJ and make a wide loop. Because if it's a narrow fixation, there is always a possibility of twisting and obstruction.
Anupam, I think I can't find Harinder. Uh, uh, is it necessary to admit all the patients? Whoever comes with whatever small amount, big amount, because I read somewhere if it is less than 20 ml or some criteria that you may defer admission.
So obviously, sir, that things are not clear with our patients. So that is the thing you should understand. The history is not reliable. People say that 1 tablespoon, 2 tablespoon, but when you do endoscopy, you find extensive injuries. So unless the history is reliable, you need to admit all these patients. So if the history is reliable, you are very sure that it was the, I mean to say, weak acid or alkali, it's okay. But otherwise, all patients should be admitted and evaluated.
Okay, because, sorry,
Yeah, I
continue.
will agree with that, because I mean most of the time the history is not reliable, and
Yes.
in India again with the absence of appropriate labels, so we don't know what is the concentration,
Yes, exactly.
how much is the dilution. So these things are important in determining the outcome.
And
So,
sir, one
so regarding this bleeding issue, suppose in day 7, day 8, a patient comes with about some 50 ml of bleeding from mouth or hematemesis, how to go about it? Because it is said that most of the 90% of the bleeding are from the stomach, and they usually stop on their own. What is your opinion on that? But I found some people being very aggressive. Vomiting means they go for CT angio, they go for endoscopy. Yeah.
Yeah, I think we should closely monitor the patient if the hemodynamics are stable, and if it's a small bout of bleeding, it doesn't recur within 48 or 72 hours, we can leave it like that. If there is recurrent bleeding, and then we should be looking for the erosion, because most of the time what happens is day 6, 7, the mucosa will slough out, and this will lead to small amount of bleeding which can be vomited out. So this is usually the case. But again, one should be I mean, always on a lookout for a more catastrophic event.
So I'll share some of the data, sir, and what we have experienced our data. So almost all these patients bleed when the ingestion is acid, because the acid causes these kind of mucosal sloughing, and after that, and it is typically the largest series only of 12 patients. Almost all have sentinel bleed. So any bleed should not be ignored in this patient. All patients should be admitted. At least should, it's not that all patients require CT, but should be evaluated. I mean to say, should be monitored. As sir said, these patients should be monitored with HB, and you should look if there is any drop in HB, there is any melena or repeat hematemesis. You should always evaluate this patient if required with a CT. Endoscopy as such, management wise, nowadays we are having certain products which can be used, but by far whatever data we are having, endoscopy is not beneficial to management. For the management purpose, it is just what extent of resection you need to do, that can be decided based on the endoscopy.
how many of the sentinel actually go on to bleed
Sir,
requiring
so
surgical
that is the problem, sir. What data we are having, 12 patient, larger series, all have. So it is not in the prospective manner that how many had sentinel bleed and how many developed massive. So it is the other way around what they presented, that 12 patient had massive bleed and all had sentinel bleed. And in my experience, if you'll ask me, so it's just like 1/3 have sentinel bleed, does not proceed to massive bleed, but rest all 2/3 does proceed to massive hematomesis. So for all practical purposes, this should be evaluated. This should be hospitalized. This should be evaluated. So we have lost certain patients because in the COVID time, because when people were not admitting these patients frequently, we have lost these patients just because of massive hematomesis, because the initial bleed was sentinel. From the emergency, they deferred admission just because of the COVID issues. Then these patients died. When we tried to contact them, we found that the patient died because of massive hematomesis. So all these patients should be monitored extensively.
So what is the role of MRI in place of CT? I'm not read. I'm not read. It just came to my mind.
So, sir, for what purpose you are asking? That should be clear. Whether you want to, whether you are asking for.
Can I use CMRI in place of CT to evaluate these patients?
So
will it be better? Will it be?
So no one has actually compared MRI. First of all, sir.
Yeah,
Second
why I
thing,
asked this question.
it is costly affair. It takes 45 minutes for the whole screening. The CT is in 45 seconds compared to MRI, which takes 45 minutes, gives you same amount of information. Obviously, so that is the reason you are using CT, but so far no one has compared MRI with any of the other modalities.
Secondly, the
US,
issue will
sorry, Vikas.
Second issue will be breath holding with MRI.
Yes.
Even I didn't encounter any report with of MRI in corrosive ingestion, acute corrosive ingestion particularly.
No.
So, yeah.
No. US.
So US, sir, people have done, but not for the in-hospital outcome, for the development of stricture. So there are few studies that if the, I mean to say, the edema is throughout the reaching till the adventitia, so these are more likely to develop a stricture based on the thickness. So people have used US. So they did US in all the patient by day 7. There is only one study on in acute caustic. So, but the endoscopy is as good as EUS in predicting the stricture. So what additional it is providing, it does not provide anything else. So that is one point. That's why people stopped using this investigation, and there are no further studies on EUS. And again, you actually enter blindly with the EUS. So the risk of perforation is much more compared to the forward viewing when you are using the endoscope. So obviously there is fear of perforation. So it's much more risky without getting any additional benefit. So I don't think EUS should be used in all these patients.
So because you can carry on, before that, I just wanted to ask one question. Patient on day 3, day 4, day 7 is going on coughing. So what are the causes and how to go about it?
Yeah, I mean, if there is persistent cough, the first and the foremost thing which comes into mind is development of esophageal fistula. So he should be evaluated for that. Secondly, the patient is developing a hypopharyngeal stricture and he's having recurrent aspirations and he's coughing. So in both these situations, endoscopy, if initial endoscopy has been done, a relook endoscopy will give us an answer on that, what exactly is happening. So normally, if it is a fistula in the intrathoracic part of the intrathoracic part of the trachea, that becomes a very difficult to manage, because then the only thing is we will wait for the esophagus to form a stricture so that nothing goes down and the patient doesn't have symptoms. And secondly, if the fistula is in the neck, then it's better to do higher up in the neck. It's better to do a tracheostomy and bypass the fistula in the acute setting, and then we can definitely we can manage the tracheoesophageal fistula definitively subsequently. So secondly, development of hypopharyngeal stricture and recurrent aspiration as a result of can be a result of coughing. So that becomes a very difficult to manage. Patients will keep on having recurrent aspirations. The better solution will be before the discharge of the patient, we put a gastric or nasojejunal tube to the patient so that something goes for the nutrition also, and peritubally some saliva can be can go. But again, the patients will keep on drooling. Patient will have to be spitting out all the saliva all the time. So that becomes a difficult problem, because these are the group of patients who will not finally end up in having a definitive reconstruction if whatever you do in the acute setting. That becomes difficult to manage.
No stenting in acute setting.
Stenting, I think Anupam will be in a better position, sir.
No role of stenting.
Even yeah, if stenting is to be done, I think it is better to stent onto the trachea rather than onto the esophagus.
Yes. So
that's
right,
a very
yes.
a very important point. Yeah. Yes, Anupam, add one or two lines to this.
Sir, it is rightly said by sir that it is better to stent trachea rather than going for esophagus. There is no data on esophagus because all these stent will migrate, eventually will migrate, because the stent sizes come less than the actual esophageal diameter. So stents you can only place when you are having a stricture, and it should not be placed in the acute setting. There is no point of placing in if you are suspecting or having perforation in the esophagus.
Is there any chance that they would heal in due course?
So, sir, there is one patient, obviously it is just a case, not a series or too much amount of data I'm having. There is one patient, which the patient was a young female. She had extensive involvement of the esophagus in the stomach, was intubated because of the aspiration and respiratory component, but was not having fistula. But the CT showed peri-esophageal layer. So the point was whether to go ahead with the surgery for this patient or not. So we just actually managed this patient with the tube only. And later on, this patient is right now with our follow-up. So obviously, if a patient is asymptomatic, you can try to manage them conservatively with just tube, but you should be very cautious. You should monitor them regularly, and at any point of depreciation or kind of any kind of worsening, you should upfront or immediately operate these patients. You should not manage conservatively. So these are only case kind of things where we have managed conservatively.
I have read somewhere, and they can really heal in 1/3 of the patients, depending upon the grade of
sir,
injuries.
that is actually the strictures when perforate, they does heal. There is no doubt. When it is because of the extensive necrosis, then obviously you are worrying that this injury can penetrate further. It can go into the bronchus. So that is our concern. So in the acute setting, the surgery is not because it cannot heal conservatively. The problem is if it has gone beyond the esophagus, it can further damage the aorta, it can damage the bronchus. And that is the reason that people have advocated that these patients should be operated upfront.
Okay, because, yes.
Regarding one more comment regarding tracheoesophageal fistula is that sometimes what is happening, this is again a aftermath of acute injury. Basically, esophagus form a stricture, and then we sometimes the proponents who don't advocate resecting esophagus in the chronic setting, they will do exclude the esophagus and do anterior mediastinal bypass. So once the esophagus is excluded from top and bottom, then automatically the fistula will be taken care of. There will be no aspiration with that.
So because we are, with your permission, we are having 3 or 4 minutes.
Yeah,
if Dr. Chetan wants to say something, or Dr. Anurag Govil is there, you can give your comments or suggestions, sir.
No, I wanted to ask Dr. Anupam. He mentioned about the 12 cases with severe hematemesis. So basically, this hematemesis would occur only because of sloughing, extensive sloughing. So these are the patients who are also likely to have perforation.
So, sir, actually that data is not mine. Mine data is of 8 patients, not published so far. So whatever data we are having from the West, that is of 12 patients. So these patient initial injury was having either 3B, but that was on endoscopy. So whether it was complete necrosis, extensive necrosis, that is not sure, but almost all of these patients on the surgical specimen were having extensive ulceration. And that is by nature of the acid that it actually damages the superficial tissues or superficial mucosa and submucosa. So once the damage is done, the submucosal layer or submucosal vessels are exposed, and these are basically the vessels which bleed. So these are not, there are no, I mean to say, muscle to cause spasm in these vessels, and these bleeds are predominantly, I mean to say, from the veins rather than from the arteries, and that is the reason the CT angio does not pick these vessels. So there is only one case report in the world literature where they were able to manage through the angioembolization. Otherwise, all underwent surgery.
Surgery. And could you, because Dr. Dash said that you are carrying out a trial, randomized control trial with regards to FJ with nasojejunal tube. Could you just tell us more about it? What are your findings, and then how do you select your, is it randomized or you select your patients for NJ?
No, sir, it is randomized. So what trial is actually what we are doing? We are excluding the 3B injury on endoscopy, but with CT showing extensive necrosis. So CT should have a 3B injury or 3 injury, grade 3. I mean to say, okay, we should be sure that the patient are having complete necrosis. So those we are excluding. We are excluding the patient on day 5 if they are having low grade injury, because they are less likely to develop a stricture. So there is no point of putting tubes in these patients. So only we are taking the selective group, I mean to say, on day 5, those who are having 2B injury or 3A in the stomach or entropyloric or in the esophagus. So only in these patients, this subset of patients, we are randomizing into either FJ or into the NJ or NG, depending on if the only esophagus is involved, we are only putting NG, NG, or if the stomach is also involved, we are putting NJ, nasojejunal tube. So this is what our trial is. But what is important, in day 1 also we are doing an endoscopy, but to actually, I mean to say, exclude those patients where we are overestimating the injury, we are repeating endoscopy on day 5, and only on day 5 we are deciding whether to put in the trial or not.
Okay. Thank you. Thank you very much.
Dr. Anurag?
Yeah, sir, good evening.
Yeah, good evening. We'll have an extensive dissection now. The stage is set for you tomorrow. And Dr.
Yes, sir.
Chetan.
I had just one single comment to make,
Yeah,
and this
please.
is just a case which has, of course, not been reported, and because it holds relevance, relevance to what is being discussed right now. This is regarding hematemesis. So there is this patient who had history of frank blood hematemesis soon means 2 to 3 days after the corrosive ingestion. And subsequently, the patient did well, developed a stricture of the esophagus. A CT done about 7 days after the ingestion did not reveal any esophageal aortic fistula. But after the first dilatation and before the next, this patient presented to the emergency with massive hematemesis, absolutely fresh blood, and died in the emergency itself. So the suspicion, of course, was an esophageal aortic fistula. I don't know if the panelists have seen this kind of a happening before. Even we have seen this only once, and it was just to highlight, the severity of a bleed which can happen, and the role of maybe more better assessed uh, CT scans and evaluation for patient who present with hematemesis as part of their symptomatology.
Yeah, I can share with you. We have seen experienced one case like that. Actually, we suspected because there was no way we could find out where was that, but the patient came collapsed, um, and sit just at the last moment did the ultrasound. It was blood everywhere, so it was possibly that. And one definite case of esophageal injury involving the IVC, the lower end, causing bleeding. Of course, because of lack of time, we didn't discuss injuries other than stomach or esophagus. We have seen injuries to the liver also, and bile duct, gallbladder necrosis, extensive bowel necrosis. All those areas, all those things are there. And though no series for that, but definitely I think all of us must have experienced these extensive type of injuries. And also we couldn't discuss about the toxicity of the corrosive itself in the post-operative period. Some say that they get chemical toxicity, and they can die much earlier than you expected. Some of them, they die, we have no explanation why they die so quickly. And in some of them, we have seen liver enzymes going on to 5,000, even 8,000 in those patients. It is described autoesophageal fistulas in very deep corrosive injuries, anecdotal, of course. And your experience, of course, substantiates that
Fact,
statement.
we had two patients, experience of two patients being diagnosed, and one of them was operated. One patient with aortoesophageal fistula following corrosive ingestion was diagnosed on CT angio, but he succumbed to bleeding before we could wheel him to the operation room. And second patient of aortoesophageal fistula we managed. It was not related in context with the corrosive injury. It was context with some other mediastinal infection eroding into the esophagus and that. And in that patient, we could do a esophagectomy, aortic replacement, and all that. But again, that patient also died in the post-operative period.
Aortoesophageal fistula, because of other causes, have been managed in our CTVS setup, and I think nearly 10 of them have been managed, autoduodenal, autoesophageal, and I think we have had a fair bit of success. It's about some 70% or so, and same day or next day we have lost 3 patients out of this, around 9 to 10 patients is there. So, because now, if you have some concluding lines, then I'll have 1 or 2 lines and we'll finish. It's 9:07.
Yeah, so okay, I mean, it was a nice discussion and encompassing almost all the aspects of the acute corrosive injury. And with this, we can conclude the session. Dr. Dash, any last?
What I was saying, because it's my inner feeling, which I have observed. I'm saying, see, the management of or the corrosive injury of the esophagus or stomach, upper GI, itself is a very difficult situation. It is difficult for the patient, lifelong difficulty, isn't it? Then if it is really severe, it is difficult for the medical team, be it the gastroenterologists, surgeons, or radiologists. If you say it is a difficult situation for them, it is also difficult for the examinees. That you must have felt that in every MCH exams you will have one corrosive, and that would be the Achilles heel of all the candidates. So our aim here was, actually, this was a master class, so we try to ask to answer questions, mostly what we feel we ask them and they ask us back during the rounds. So we have covered most of them, and the journey of a corrosive injury is really very, very long and tedious and strenuous. That the day the patient has the injury, if it is severe, then he goes through a lot of phases till he becomes normal and have a normal quality of life. So we have only covered half of it, the acute part of it, and the chronic part, the sequelae, the complications are remaining. That we will discuss tomorrow. And I am collecting a set of theory questions on corrosive injuries. I have collected, and if you can supplement some of them, then I think we should take few minutes. All teachers are here, and we can discuss. Mostly, this is being asked by my resident to me, sir. Exactly, tell me how to answer this question in the examination when we don't have much of evidence at hand. So we'll try to answer a few of them. I'll send those questions to all of you. We will discuss that one. So looking forward to a very competitive and energetic discussion tomorrow. Dr. Chetan is there, Dr. Anurag will there. It will be very fascinating. So with that, with all of your permissions, thank you, all of us. Can we close, Vikas?
Yeah, definitely. We can close the session for today, and we'll see you tomorrow evening. Yeah.
Thank
so
you,
much.
Chetan sir. Thank you,
Thank
Dr.
you, sir.
Anurag.
Thank you
Thank
very
you,
much.
Anupam.
Thank you, sir.
So we can leave now. Thank you,
Thank you
Professor
very much.
Kapoor. We missed you, but we will be with you tomorrow. And we will also cover some of the surgical aspects of acute injury when we discuss the surgical aspects of chronic injury tomorrow, because.
Yeah, definitely. Yeah. Okay.
Thank you. Bye.
Thank you. Merry Christmas.
Thank you. Wish you all
Merry
the same.
Christmas to all of you.